Hello, everybody, and welcome back to my YouTube channel. After a break, I am back with a very important topic related to critical care, that is, airway management in ICU. Now, people who are from the background of anesthesia get a very structured and training for management of airway during their courses, but there are some challenges which will be there when you manage airway in ICU, which may not be same like when we are dealing in patients in operating room. So we'll try to highlight all those points during our next 30 minutes journey and try to see what are the current evidence and how we can address those problems. We'll start with a case, a 61-year-old lady with a background of carcinoma base of the tongue, which is progressed locally in the recent past, and she has received two cycles of chemotherapy. Now, this time she is admitted with a neutropenic sepsis with septic shock at 11 p.m. at night. To optimize his hemodynamics, she is requiring noradrenaline and vasopressin at a very high dose. Repeat blood gas shows that there is a persistent metabolic and respiratory acidosis with a pH of 7.25, and it has not resolved with fluid resuscitation over last 2 hours. This patient has an anticipated difficult airway because of restricted mouth opening, which is around 1.5 centimeter. So when my on-call fellow called me and asked about my opinion, I suggest him to intubate immediately. But if you look at the other side, patient is fully conscious, obeying command, mild tachypneic. So she has already put on prophylactic NIV with requiring around 5 liter oxygen. Because it's a difficult airway, so as per our protocol, we call the anesthesia fellow, but he feels that there is no indication for intubation. Because the difficult intubation with the restricted mouth opening, so we also call the head neck fellow. So look at the feasibility of tracheostomy if there is a failed intubation. He also found there is no indication for tracheostomy at this moment. But why an intensivist is thinking differently compared to the anesthesia fellow? Now, if I share my concerns, now this patient has a metabolic and a respiratory acidosis. That means he is not able to compensate adequately for his metabolic acidosis, non-resolving lactic acidosis. This patient on a very high dose of NORAD and vasopressin, and what will happen eventually in due course? His respiratory muscles will get fatigued because of inadequate blood supply. His respiration will gradually become shallow, and the rate will decrease, and there will be precipitous worsening in the respiratory acidosis. And as a result, the overall pH will fall very drastically, creating an impending arrest scenario when you need to intubate this patient on an urgent basis in a pericardiac arrest scenario. And being a difficult airway, that will be very, very challenging. So that time you may need an emergency tracheostomy also. That's why I give a referral to the head neck tip. And in this type of situation, it is much better to take control over the airway, specifically if it's the anticipated difficult one, to control the ventilation of the patient. Sorry. So you look at the indication of intubation in ICU. It can be because of airway. That is, the patient is not able to maintain airway, maybe retaining secretion, not able to cough out, or maybe upper airway edema. It can be related to respiratory, like inadequate oxygenation and ventilation. Patient may be in severe hemodynamic instability, that is shock, either cardiogenic or septic, whatever. And as a result, there is a decreased perfusion to the respiratory muscles, who are basically voluntary muscles to some extent. And as a result, they will eventually get fatigued and patient will develop a worsening or impending respiratory failure. It can be because of neurological also, when patient because of poor sensorium is not able to cough out secretion. And even severe metabolic acidosis because of renal cause, you may need to intubate this patient to get a control over its ventilation. Because with a decrease in pH, all the metabolic parameters will become compromised, and as a result, the muscles, respiratory muscles, may not function adequately in due course. At the same time, Airway management in ICU is always very challenging. Why? Because these patients are unstable with a limited physiological reserve. The comorbidities are not optimized. The clinical stakes are very high, along with this tremendous time pressure. These are inappropriately positioned. You cannot get the optimal head positioning of the patients because they are critically ill, they are restless. The immediate environment may be less than suboptimal because in the middle of the night, you're not going to get an extra hand all the time. We do not have much flexibility to evaluate the airway beforehand because in acute situation and probably have to consider them as a difficult airway. And it is very difficult to get an optimal intubating condition. Like that means you are not able to use adequate sedation and muscle relaxation as you want to be. And if you look at the real-time incidence of complication, it can be as high as 18 to 38 to 13%. When for anesthesia, people that complication rate is very, very less when you are doing the same procedure in OR. Now, if you look at the real-time complication, I just quote two papers. One from the year 1995, when they look at the intubation process in 297 patients in OR and ICU, ER and ICU, this is an emergency and ICU, and they found there's a significant correlation between hypotension and peri-intubation cardiac arrest. They found that peri-intubation cardiac arrest incidence is around 3%. What are the other complications? It's difficult intubation, esophageal intubation, aspiration, hypoxemia, and hypotension. Please remember the incidence of cardiac arrest around 3%, which is significant compared to any anesthesiologist that he or she has experienced in her OT. Another paper from BJ in 2012, they look into 794 patients and they found that 91% cases there is a successful first pass intubation. That means on the first attempt, patient was got intubated. Even after that, they found that acute respiratory failure and shock as a primary cause of intubation as an independent predictor of complications. And the complication can be as high as 40%. This is a recent multicentric observational, prospective observational study, and Dr. Shaila Mitra from India was one of the lead person in that. They collect data from 29 countries. What they have found, the complication rate in ICU and emergency department can be as high as 45% while intubating these patients. And contrary to the common belief that probably hypoxia will be the important cause or most important cause of complication, this group found that the cardiovascular instability is the most far more common than any other complications, and it can be as high as 40%, but the hypoxia is around 9%. And they found that the cardiac arrest, which is nearly 3% in peri-intubation period. You remember the previous article I mentioned? So even after 20 years, 25 years, when we have much better gadget for intubation, we have much better understanding, lots of protocol, still the peri-intubation cardiac arrest is nearly same compared to our 30 years, 25 years previous experience, which is very alarming. But why exactly that? That is because of the concept of physiologically difficult airway. Because in ICU and ER, emergency department, this patient's physiological condition is so challenging. So optimizing them while during the procedure can be difficult. And because of this patient may develop a higher risk of peri-intubation arrest. This is All India Difficult Airway Society guidelines for intensive care intubation, and they have mentioned that there are patient factors which are really challenging, like challenging anatomy, last like in our patients. Inefficient pre-oxygenation, we'll discuss those things. Rapid desaturation because of increased physiological requirement, on the contrary of decreased physiological reserve, hemodynamic instability, and very importantly, waking up the patient in case of failed intubation is not an option. Have to secure airway, at least you have to ensure oxygenation of these patients till you get a definitive airway. When you look at the components of airway assessment, history taking is important if you have time. So in that situation, we'll look into the previous medical record, surgery, any history of burn, trauma, tumor, radiation in and around the oral cavity, or any known pathology of neck and cervical spine. Sometimes you will get, sometimes you will don't. On general examination, we can look for any evidence of upper airway obstruction like hoarseness, hoarse voice, or any other definitive anatomical factor which can make it difficult, like our patient's restricted mouth opening. If these findings are there, you can definitely consider them as a difficult airway and should have a backup plan. And there are different tests and indices which are available in the market and is used by anesthesiologists during your in OT, but whether they are applicable in ICU or not, we'll see. There's very limited data for them. So my working principle is that if the first impression is the best impression, and if it looks difficult, it is difficult. So we don't need any indices, any evaluation to see this patient has a difficult airway of a orofacial trauma, or patient with a restricted mouth opening, morbidly obese patient, or these kids with different congenital anomaly like Apert syndrome, Pierre-Robin, Treacher-Collins syndrome. So after that, if you move to the physical examination, I've already mentioned that time availability for physical examination is very, very limited. So what we can do, we can look for certain non-reassuring signs, non-reassuring findings, which will tell us that this patient's airway is difficult, like probably upper incisor, relatively long upper incisor. When you look at the relationship of maxilla and the mandible, if there is a prominent overbite, that means the mandible cannot move in front of the maxilla. Inter-incisor distance, the mouth opening is less than 3 centimeters. When I ask them to open the mouth like a part of malumpati, not able to visualize the uvula, which makes a malumpati more than 2. Shape of the palate, if it is very high arch or very narrow, because your flange of the flange will be adjusted into that space, flange of the laryngoscope. Compliance of the mandibular space, because you have to elevate it to get an access to the vocal cord. Thyromental distance, length of the neck, that if it is short and thick, it will be difficult, and range of motion of the head and neck. If you get multiple findings of this type of non-reassuring signs, probably your airway is going to be very, very difficult, along with the physiological challenges. So when you're not able to sure whether we can intubate, we always fall back for ventilation. So there are scoring systems which tell us about the difficulty in ventilation. We say bones or moans, which include beard individual, obesity, no teeth, elderly, and patient who are snorer or obstructive sleep apnea. Along with that, moans have an advanced age or any evidence of upper airway obstruction. So when you look at the difficult laryngoscopy and intubation and the scope to predict it, there are different scoring systems and there are different meta-analysis for the bedside screening tools, but most of them have shown that it has a poor to moderate discriminative power while identifying the risk of difficult airway. The best possible combination is Mallampatti and thyromental distance. If you look at the cervical spine and the adductor joint, the standard or conventional teaching is that we should put the patient in the sniffing position or called Magill position. That means flexion at the cervical joint by 25-30 degree or extension at the atlantoaxial joint, that is by 75 to 85 degree. Now, if we are not very sure about the movement of the neck, what we can do, we can look for other signs called prayer sign or pumpkin sign. Prayer sign and pumpkin sign indicate the pathology in the small joints, and it can be a surrogate marker of restricted neck muscle, restricted neck joint or cervical joint movement. But when you look at the radiological evaluation, we find that sniffing position should not be the ideal position for intubation because it does not make the all three axes, that is the oral, pharyngeal, and laryngeal, into the single line. So unless you get that, then obviously your intubation is going to be difficult. So probably we have moved away from getting our patients into sniffing position while intubating them. Adequacy of oropharynx is important, already mentioned. Standard is Mallampati grading along with Samson and Young's modification. That is class 1, class 2, class 3, and class 4. Ideally, we should evaluate this with the patient sitting in front of us at the level of our eye. But in ICU, we get patients who are lying down in front of us. So if we evaluate Mallampati in lying down position, apparently it looks a little more difficult by one grade. That means if someone has a class 2 malampati in sitting, in lying down it will be class 3. Along with that, narrowness of palate is very important. As I mentioned, we try to accommodate the flange of the laryngoscope into that space. Now, most confirmation is the by a check laryngoscopy. It can be difficult, but if you can do a check laryngoscopy, look for the Cormack-Lay hand, you can see the vocal cord by any means. Then either you can put a tube or you can put a bougie and can intubate the patient over the guide wire. So if it is possible in your patient, better to look for a check laryngoscopy. There are different group indices, but practically they are not able to use it in our practice. Maximum we can use, which is called Lehman's law. What Lehman's law include? It include it's a mnemonic. L for look externally. E that is evaluate 332. That is 3-finger mouth opening, 3-finger hyomental distance, and 2-finger thyromental distance. Malampati classification, any evidence of obstruction, and the range of neck mobility that my patient has. I think that's maximum that is possible in a critically ill patients. Now, if you're not sure whether you can intubate or ventilate, next option to fall back in a critical situation we know that is difficult supraglottic airway. Now, in a critically ill patients, there are factors like mentioned by mnemonics called ROADS, that is restricted mouth opening, obstruction, disrupted or distorted airway, and stiff lung or spine. They makes the external glottic airway insertion difficult. That's why extraglottic devices has never become very popular in ICU. They can use only as a rescue measure. Then nowadays there are different kinds of advanced extraglottic airways are available, which help us to get a much higher airway pressure, can help them to ventilate even with a little pressure. They have a gastric port to deflate the stomach. So in a crisis situation, it can be used for a rescue measure. And the last is the difficult surgical airway, like in our patients, because it's a difficult airway, we should evaluate for difficult surgical airway also, like previous surgery in front of the neck, any hematoma, obesity, any history of radiation, and any presence of tumor. So we have seen patient with such a huge thyroid mass with a tracheal compression that if we fail to intubate, this patient is not in a position to get any surgical tracheostomy. That makes our life really, really challenging. Now come back to the physiologically difficult. We already discussed regarding the anatomical challenges in ICU. Those things will be there. Along with that, physiologically difficult airway and related challenges will be add on. So there are 4 factors which makes patients physiologically difficult or patient's airway: hypoxemia, hypotension, severe metabolic acidosis, and right ventricular dysfunction. Because all these things create a decrease apnea time and make these patients to develop or prone to develop more hemodynamic instability and arrhythmia. Can you measure them objectively? Yes, there's a scoring system called Makocha score, which involves some factor related to patient like Malampati scoring, presence of obstructive sleep apnea, reduced mobility of the cervical spine and limited mouth opening, factor related to pathology of the patient, that is whether patient is comatose or having severe hypoxia requiring around 80% oxygen or saturation is less than 80, or factor related to the operator like a non-anesthesiologist. Presence of an anesthesiologist makes the intubation easy or more safe. So Makocha scoring has a 0 to 12 when 0 is easy and 12 is very difficult, and it has a sensitivity around 73%. But this has not been validated in video laryngoscopy. That means it is done for conventional laryngoscopy. Presence or usage of video laryngoscope has changed the game to a significant extent. Now, how to manage a difficult airway? This is a standard algorithm by American Society of Anesthesiologists, which I have read in our student life in 2010, 2012. But few factors are still very, very relevant. That we have to identify along with intubation, whether difficult ventilation, whether difficult to get patient cooperation, or difficult tracheostomy. We have discussed. Actively pursue opportunities to deliver supplemental oxygen throughout the procedure of difficult airway management. This is very, very important, and presently it has taken significant leap ahead in terms of our understanding and practice. We'll discuss in detail. And also, we have to take a call regarding whether I'm going to be awake intubation or awake under anesthesia, non-invasive or an invasive technique like surgical or not, or whether the patient will be in a spontaneous ventilation or I am planning to paralyze the patient. So these are the four questions I will really ask to myself. Is the mask ventilation likely to be successful? Before giving any anesthetic drugs, before giving muscle relaxation, I should ask, can I intubate this patient? Third is there any obstacle that makes the fiber optic intubation likely to be difficult, like there is an active bleeding in the airway? Or if I failed in this thing, what is my rescue plan or plan B? Present recommendation is that whenever you are intubating, better to have two operators specifically for ICU intubation. And one of them is preferably have a good experience in airway, and preferably from the background of anesthesia. Next, as I mentioned, because these patients are sick, so pre-oxygenating them is very, very important. We also pre-oxygenate patients during intubation in OT, but they have a reserved normal lung with a prolonged apnea time. But what can be done in ICU to improve the quality of pre-oxygenation? So options are supplemental oxygen by nasal prong, face mask, high flow mask, NIV, or high flow nasal cannula or thrive. So ideally, we should keep the patients in little bit head and up position, 15 to 30 degree. If I pre-oxygenating with NIV, it should be pressure support with PEEP. For nasal cannula, you should use the maximum possible oxygen, that is 15 liter, and for HFNC up to 70 liter. But we need to understand it's not only about denitrogenation because the already underlying lung is small, so the functional residual capacity is less. At the same time, patient has an increased oxygen consumption because of high metabolism and because of sepsis. So there is chance of faster hemoglobin desaturation and it will decrease the safe apnea time. And that parallelly, because the patient has a ARV pathology, that is ARDS or other pneumonia, so the residual lung, functional lung, which is called baby lung, is less, leading to decrease in FRC. And there is also a underlying shunt pathophysiology. Because of that, the AA gradient will be high. So because of that, whenever we have used HFNC as a pre-oxygenation in ICU, only as a pre-oxygenation measure, it was never that successful. This is a paper where they have been used for 197 patients undergoing general anesthesia. They could not document any obvious clinical benefit, though this group of patients has a higher oxygen reserve index. But with this increase in oxygen reserve index was not statistically significant. Similar result has been echoed in a meta-analysis involving 5 studies that include 235 patients. They also show that patient has a higher PO2 after intubation with HFNC and Thrive compared to face mask, but no difference in apnea time, oxygenation time, PO2 and PCO2 level in these patients. And whether to use HFNC for pre-oxygenation, the world has been divided into 3 groups. Some feels yes, some feel no, and some feel maybe, and we can use it in a case-to-case basis. Now, all these 3 editorials have been published in Intensive Care Medicine, and they are worth reading to get a understanding and the pros and cons of using HFNC for pre-oxygenation. And that's how we have gradually moved or from HFNC or along with HFNC, we are using towards a positive pressure ventilation or NIV. So look at the left picture, the lung is normal, and if you give oxygen, it gradually replaces the nitrogen, and eventually the apnea time will increase. But on the other hand, in the right side of the picture, in the ARDS, you can see the very small amount of lung is functional. So even if you replace the nitrogen in that part, it's not going to increase your apnea time significantly. It is much better if you can give a positive pressure and can recruit a bit of the alveolus. That will improve the oxygenation status. So in both situations, patient may have an excretory oxygen concentration more than 90% with an HFNC, but the functional apnea time may not increase with HFNC, but it may increase with a positive pressure ventilation like NIV. So if you look at the scope of positive pressure ventilation and pre-oxygenation, it has been used previously as a bag mask while before intubating the patients. And when they compare bag mask ventilation with no ventilation, from induction to intubation to decrease the risk of aspiration, in a group of 401 patients, they found that average oxygenation level was less in no ventilation group and thought though it was not clinically relevant. But when you look at the subgroup of severe hypoxia, They found that no ventilation group without any evidence of that they found severe hypoxia is more in no ventilation group without any increased evidence of complication like aspiration and chest infection. So this has been a practice even in a patient with obstetric patient during in pregnant uh, full full term pregnancy when the risk of aspiration is high and the patient is desaturating. Sometimes we do a small tidal volume back mask. Similar data has been echoed in post hoc analysis by McMahon trial when they evaluate 371 critically ill patients who undergo intubation in 7 different French ICUs. They used 4 different pre-oxygenation devices and they found that while intubating hypoxic respiratory failure patients, non-invasive ventilation has least chance of critical desaturation. Now, along with pre-oxygenation, in ICU, what we do, we also practice apneic oxygenation and we try to give some oxygen during the process of the intubation. So it can be given by nasal cannula or by HFNC. Nasal cannula also first been evaluated in a study called No Desat study. When they use nasal cannula and oxygen by up to 15 liter, it allows apneic oxygenation to continue while the patient of attempt of tracheal intubation was continuing, and it increased apnea time by 2 to 5 minutes. So then comes the thrive. So advantage of HFNC for using for pre-oxygenation is that you can continue it for apneic oxygenation also. And we can use up to 60 liter of oxygen with a warmed humidified nasal gas. It combines the benefit of apneic oxygenation along with continuous positive pressure and gaseous section happens through flow-dependent day space flushing. It can create up to 5 to 7 centimeter of water pressure depending on the flow. It increases apnea time by enhancing the apneic oxygenation and provide apneic ventilation. As a result, reducing the rate of rise of PCO2 to approximately one third of the expected. And it can increase apnea time by around 14 minutes on an average. What people has done, they have combined both. In Opti-NIV trial, people they have combined HFNC along with NIV for pre-oxygenation to get a positive benefit. And the risk of desaturation during the process, during the intubation, which was less with HFNC plus NIV compared to NIV. And similarly, it has been used in other studies, HFNC versus NIV for pre-oxygenation in hypoxic patients used in 313 patients with 28 ICU, and there's no difference in hypoxia in terms of desaturation. But in hypoxic patients with a PO2 FR2 moderately hypoxic patient, PO2 FR2 less than 200, NIV showed a better safety profile compared to HFNC. And it has been shown again in other meta-analysis involving 7 RCT with 796 patients. The severe complication that is including cardiac arrest in patients was less in this subgroup patient was less with a combination of HFNC plus NIV, that is pre-oxygenation and apneic oxygen, compared to simple oxygen delivery. Similar advantage with a morbid low base patient also compared to conventional face mask, NIV for 5 minutes that's shown to have a better oxygen reserve index, and PO2 was significantly higher in the NIV group. It has been again shown in pre-OptiProp trial when HFNC and NIV was compared, and pre-oxygenation and apneic oxygenation in 100 patients undergoing elective surgery. They found that lowest ETCO2 was with HFNC compared to NIV, and the risk of mild deterioration and the lower median SpO2 was more with HFNC. But patient discomfort was also more with NIV because of it's a tight mask, pitting mask. Next critical point or the challenge is the rapid circulatory intubation. We need to understand it's an expert and advanced technique because we need to know what amount of pressure to give with which patient to cause the compression. It requires training and competence, and we have used to practice it in the neonatal weighing machine to understand what is the 1 Newton pressure, one is 3 Newton pressure. It comprises of few steps like pre-oxygenation, manual inline stabilization in case of suspected spinal unstable C-spine or spinal cord injury, quick IV induction of anesthesia and neurovascular blocker, required pressure, and endotracheal intubation. Again, when it has been evaluated in radiology, it shows that The esophagus, in 50% of the cases, was situated lateral to the cricoid and not behind the cricoid. So compressing the cricoid, it gives you a false sense of security that you are compressing esophagus and chance of aspiration is less. On top of that, it definitely makes the intubation process very difficult. That's why we are gradually moving away from Selix maneuver, and it makes become an optional in the descent guidelines. Much more helpful was the laryngeal view during laryngoscopy, that is required pressure, backward, upward, and rightward technique, along with bimanual laryngoscopy. Those are much more helpful. When you talk about required pressure, some point I again like to mention that application of required pressure will make the laryngoscopy difficult. Gentle mass ventilation while applying required pressure can prolong the desaturation time. A second generation supraglotic device can protect or prevent aspiration better compared to first generation because they tolerate a higher pressure. So if you are not able to intubate, insert a second generation airway device, but it may be difficult to again in case of patient with a required pressure. Neuromuscular blockage. Conventional idea a few years back was ICU patient doesn't need muscle relaxation, you can intubate them like that with very minimum sedation. But present studies has shown that neuromuscular blockage improve first attempt successful intubation significantly in ICU patients, and now they are reasonably a standard of care while intubating these patients. What about hemodynamic optimization? We already learned that hemodynamic complication is probably the biggest challenge during intubation in emergency and ICU. It has shown that cardiovascular collapse can be up to 30 to 40%, an independent predictor of post-intubation mortality, ICU stay, and hospital stay. So, what are the therapeutic options to prevent hemodynamic instability or hypotension? Fluid loading. We can use vasopressor either prophylactic or therapeutic. Studies have shown that patients who have given 500 ml of fluid bolus before intubation did not decrease the complications related to hemodynamic instability in these patients. For prophylactic vasopressors, we are not recommending it because data is not there. But if patient develop hypotension, we should start vasopressors early rather than keep on loading them fluid. Drugs, conventional drugs of benzodiazepine, propofol, and thiopentone, but because of hemodynamic instability of those drugs, gradually we are moving away from it and using more and more ketamine and etomidate. It is more preferable, specifically if the patient is hemodynamically unstable, along with different adjuncts like opioids, dexmedetomidine, and lignocaine to decrease the laryngoscopy related stimulus. A neuromuscular blockage I already mentioned, it's used to improve the first pass intubation success, both for rapid and delayed sequence intubation, irrespective of the choice of induction agent and route of administration. Video laryngoscope, the present practice has shown that use of video laryngoscope improves the outcome in first pass intubation significantly. It improves the visualization of glottis, both in ICU and emergency. Meta-analysis involved 9 trials involving 2,133 patients has shown the first successful intubation was as high as 2 times in video laryngoscope compared to conventional one. But at the same time, there are some challenges related to it also, as per NAV4 report. Non-availability is an issue for video laryngoscope or flexible fiber bronchoscope, lack of training, and failure to consider the right equipment. Now, good institutes has multiple equipments for airway. Which into equipment to be used in which scenario is a very, very important challenge and learning for the training. And you should always have a difficult airway cut with all those important aspects like all kinds of mask, bag mask with a face valve, ETC detector, suction equipment, large bore tonsil suction apparatus, which is called Youngker, and can be helpful in a trauma patient with aspiration. These are important. After intubation, you have to confirm the patient's tube position, and we strongly recommend use of capnograph to confirm the endotracheal tube position in critically ill patient. The Intube trial study that has mentioned has shown the use of capnography is significantly less even after such a strong recommendation in its favor. It's nearly around 20% in this study. And it is better to have a bundled approach to ensure intubation and confirm tube position depending on the facility that you have in your ICU. So there are different first strategies to increase the first pass intubation. Most of I have mentioned like pre-oxygenation, optimal hemodynamic optimization, utilization of the resources to have a plan A, B, C, and human factors. Among them, shock index is an important part of hemodynamic optimization. If the patient has a high shock index, the chance of developing hypotension is also significantly higher. Cutoff is equal to zero point 0.9. During intubation, maintenance of oxygenation, device selection, and medication. And after that, for the successful coordination, we need a multidisciplinary approach. We need a structured training program for the fellows and the trainees, and optimal utilization of the resources in the institute. So if you look at the IDA 2016 guideline, I have mostly discussed it. First part is pre-oxygenation and induction of anesthesia. Second is laryngoscopy and tracheal intubation, and confirm the tube position is capnography. If you fail to intubate or uh, in that situation, go to plan 3 when you insert an SDA, supraglottic device, and try to intubate on top of that or go for surgical airway. If you fail to do that, go back to rescue mask ventilation, depend the patient, give more muscle relaxant, and ventilate. And if successful, surgical or percutaneous tracheostomy. And if that is not the case and there's a complete ventilatory failure, we go for emergency tracheothyroidotomy. Just like intubation, extubation is also a very challenging process, specifically in a critically ill patients in ICU. So if you are not sure about whether the patient will be able to maintain airway or whether you can put the tube again, better to extubate them over a tube exchanger and keep it for a few hours to see. Most of the time, the patient has a failed extubation due to airway. They usually fail within first few hours. Mostly the immediate one. The early and delayed intubation failure are mostly because of neuromuscular weakness or muscle fatigue. And at the same time, we should have a plan or protocol to process for full extubation. That how we going to rescue this patient if there is a failure. Now we also have a dedicated journal for airway management, that is Airway, and we know all about the All India Difficult Airway Association. I'm presently privileged enough to work as a secretary of Kolkata branch. I try to do more academic program in my city and would love to be collaborate with other people in coming days. By this, I like to conclude my presentation. We're very happy if people approach me with their queries. I will try to answer them at my capacity. Thank you.